Great to be here. Thank you very much, Esther, for the invitation to be here. And I'm glad I can speak to you all this morning from sunny Scotland. We had a few technical difficulties, entirely my fault with setting up the presentation. So thank you for your patience in getting started. So today I'm going to share a little bit about our work in metabolic psychiatry, and I'm particularly focused on the ketogenic diet for mental health conditions. And this has been an interest of mine for some time, initially coming from personal experience, leading into research. So I'd like to show you today a little bit about the research we've been doing at Edinburgh, but also how we've kind of come to develop this into a kind of larger field from our initial pilot studies. So I'll pull up my presentation here, just a second. Let me share my screen here. Okay. So hopefully you can all see this. And I'll actually share the sound from my screen as well so that you can hear some videos that I'm going to share. Sure, I've got some patient experiences. So I'll share sound. Okay. Can everyone see okay? Could you give me a thumbs up if you can see that okay?
Yes, good so.
Yeah. So I'm Dr. Iain Campbell. I'm the Buzuki Research Fellow in Metabolic Psychiatry at the University of Edinburgh. And these are my disclosures. So today I'll talk about metabolism at the roots of psychiatry, then a pilot study of a ketogenic diet for bipolar disorder, mechanisms of action, and then perhaps a look at the bigger picture of this research. So we'll kind of zoom where in psychiatry and have a look at the kind of roots of where psychiatry started and how treatment developed. And then we'll start to look at why this might be related to ancestral health and kind of evolutionary aspects of psychiatry. So people often, I think my work is, primarily associated with ketogenic diet, and that is the case. That's my main research focus. But I actually see clear links between the work we're doing in metabolic psychiatry and some of the early work in psychiatry, even in pharmacology. And so I'd like to try and give you a framework for understanding how treatment has been approached in psychiatry, which has then led into kind of modern metabolic science. So if you look at the very first definition of bipolar disorder, this was given by Emil Kraepelin in around 1921. And he basically believed that this was a whole body illness. He said it was a physical and mental health illness that involves physical health as well as the brain. And he concluded from all of his observations in his first definition of bipolar disorder in this text that all these changes indicate that in manic depressive insanity, marked disorders of metabolism must take place. So this was the very first definition of bipolar disorder written by the man who's largely considered the founder of modern psychiatry, Emil Kraepelin. So I think this is quite interesting because you have at the very start of modern psychiatry with Emil Kraepelin a clear indication that metabolism is an important feature of mental health conditions. And he related this to energy. He said patients exhibit a colossal energy for work and they're a stranger to fatigue. Activity goes on day and night. And in bipolar depression, the total absence of energy is very especially conspicuous. And he said, corresponding to the course of the body weight changes, the general state of the patients usually experience striking change. So if you read this text, he was drawing really complicated diagrams of the body weight of the patients he was treating. This is no longer a kind of common practice in psychiatry, but he was drawing graphs of their mood state changing and how their weight would change alongside these mood changes. So I found this very interesting, and actually George Robertson edited this manuscript. He was a professor of psychiatry at Edinburgh University, where I study, and he worked in the mental health hospital that's right beside our offices. So this is at the very root of all of modern psychiatric treatment, this idea that metabolism is central to psychiatric conditions. But we kind of lost this and got involved in a discussion about neurotransmission that has been helpful in some respects, but it lost a very key feature of the illness that Emil Kraepelin was trying to describe. So much of our work I see as being kind of back to the future, where we're going back to some of the early observations of psychiatrists about these conditions. So the last thing people expect me to talk about is medications in talks, but I think this is really helpful in understanding what we're trying to achieve with mental health treatment. You know, what is it we're really trying to do when we're treating people with these conditions? And to kind of understand this, we need to go back to the very first antipsychotic medication, which was called chlorpromazine. And it was introduced to psychiatry by a man named Henry Labouré in 1952. And this was considered the kind of big bang of psychiatric medications. Many of the subsequent medications came from iterations on this medication called chlorpromazine. So why was this one medication seen as important in psychiatry, and how does this relate to ketogenic diet and the kind of research we're doing now in metabolic psychiatry? This is, I think, the first time this link has been described, but I do think it's an important one because it shows that the very first psychiatrist defining bipolar disorder saw this as a strongly metabolic condition, physical mental health condition, and even the very first person to develop treatments for psychiatric conditions on the pharmacology side saw it through a metabolic lens, which I'll describe. So Henry Labouré was a French naval surgeon, a neurobiologist, a writer, and philosopher. He was a really remarkable individual. And he was very much an independent spirit who sought to challenge the existing paradigms of medicine whilst working within them. And he was dedicated to reducing the suffering of patients. Many of us with mental health conditions can have mixed feelings about medications and how they're used in treatment. And I know that Labouré shared many of those concerns about how the things he invented were used. But he really was dedicated to reducing the suffering of patients. This is what he wanted to achieve. And he actually self-funded a lot of his own research. He used his own money to fund these studies. So it was really a kind of effort of passion to try and help patients, his work. He transformed the practice of surgery, psychiatry, and he made substantial contributions to philosophy as well. I just noticed you can see on his desk actually I think it's called the Winged Victory of Samothrace. It's a statue, and it's often been a kind of symbol of independent thinkers and independent spirits. It's very interesting. I just noticed that he had that on his desk. But he was the founder and director of the Laboratory of Ethnology at Bicol Hospital in Paris. And he was nominated for a Nobel Prize for his work. But because he was so challenging to the establishment, many people challenged his award of the Nobel Prize, and he wasn't awarded it. But arguably, the impact of his work, it would have been much greater satisfaction to him than any kind of award they could have presented him with. So metabolism at the roots of pharmacology. So chlorpromazine, Laboré's central thesis developed in the mid-1900s was that psychiatric disorders are primarily disorders of brain metabolism. So keep in mind, this is the pioneering pharmacologist in psychiatry, and he was treating these as mental and metabolic disorders of the brain. He believed that mania and psychosis were underpinned by states of hypermetabolism in the brain. So mental health conditions are very confusing for patients and families that experience them. Many of the things are unexplainable that patients will do. I lived with a mother who had a very severe brain aneurysm and lived with many kind of neuropsychiatric conditions for about 10 years after this. And still she's in recovery 15, 20 years later from having this. And I find this incredibly confusing as a child to go through this experience because you know someone and you have a trusting relationship with them, and they can, they completely change when they have these severe neuropsychiatric symptoms. And I find this very disturbing as a young person to think that we were just a bunch of brain chemicals, and that if you disturb them, the person can become different. And I really wrestled this for a very long time through reading philosophy and science and trying to understand how this could be possible that someone could change so much. But what Labouré was saying was that what's happening in the brain when you have these severe kind of psychiatric symptoms is the brain is going into a very high energy state, like a hypermetabolic state. And this drives the brain on all systems and causes all kinds of very odd behaviors. But really, and then depression he saw as inhibition. He saw as this kind of a depressed metabolic state where the brain is struggling to produce energy, and so the person can't function properly. And that's quite a simple way of viewing it, but this is the kind of framework he was operating in. And his central theory he called inhibition of action. He said that the modern world inhibits our action, so it inhibits evolutionary drives that we have from our deep history. And he saw that the modern world was suppressing a lot of our fundamental evolutionary drives, and this was causing stress in the brain, which he believed expressed as states of hypermetabolism. He was actually the person where this whole idea of fight and flight comes from. So, for example, he believed that he talked a lot about the social environment, but I think many of us recognize that there's evolutionary mismatch between our light environment and our food environment compared to the conditions we evolved under. So for hundreds of thousands of years, we had no artificial light, no substantial sources of refined grains and carbohydrates and refined sugars. And so really, he was in line with this thinking. He felt that there's something about our modern environment causing the brain to go into these hypermetabolic and hypometabolic states, and he wanted to treat this. So he developed and tested metabolic treatment strategies to treat these hypermetabolic states in the brain. So that this happened in the context of the asylum. So in the 1800s, if you had a mental health condition, you were generally put into an asylum and received some very harsh treatments. You can see on the bottom right here a picture of cold wrap treatment. And what they used to do is they used to get patients and put them in ice cold sheets and wrap them up in ice cold sheets to cool them down. And they suppose that this reduced their energy and their metabolism. It made them kind of sedated. And it was a very harsh thing to undergo. I've been reading an account of this by Mimi Baird, who was the daughter of John Perry Baird, who was a remarkable psychiatrist, but he also lived with bipolar, and he was subjected to these treatments and describes the kind of terrible suffering that one would endure going through these. But they were also using insulin as a therapy in the asylums. They were injecting people with insulin until they would go unconscious. And so these were kind of very obtuse kind of metabolic strategies to reduce these kind of high energy states in patients. And Laborie noticed that chlorpromazine, the medication he was working on, also reduced body temperature, and he called it artificial hibernation. So he saw that patients were going into hypermetabolic, very high energy states, and he wanted to reduce this, and he called this technique artificial hibernation. And initially, this, as I say, was induced through cold wraps and insulin injections. But he felt a more humane way to do this would be through chlorpromazine. So this, you can see chlorpromazine reducing body temperature in the graph on the top here. So essentially, this was the kind of rubric people were using to think about mental health conditions back in the kind of mid-1900s. And he believed this medication essentially turned down the metabolic thermostat of the brain to dampen states of hypermetabolism. And the problem is this medication and many of the subsequent medications for mental health have severe and significant side effects. But the most notable side effect is they cause metabolic problems. So they reduce your metabolic function, they induce hyperglycemia, they can give you a significant weight gain. I speak to like people, young people in our LEAP groups, these lived experience advisory panels we work with in the Hub for Metabolic Psychiatry, and they get put on these medications in high school, and they can put on like 20 or 30 pounds, which can be really devastating at that stage of your life to have such rapid weight gain. But this is considered a kind of odd side effect of these medications. But in this framework, I think it makes sense to view this as actually the primary effect of these medications. What they do is they clamp down on your metabolism, and this stops you from going into manic or kind of psychotic states because the brain just doesn't have the energy, the RPMs to reach those. But it also suppresses your whole body metabolism to the point where you can have hyperglycemia and severe weight gain and inhibition of your metabolic function. So this led to this dichotomy in mental health of we need to trade a bit of our physical health to maintain mental health. We're going to lock down our metabolism to the point where we can't have mania and psychosis, but then also we're going to have to live with all the consequences of that weight gain, the cardiometabolic risk, and reduce life expectancy by 10 to 15 years in most patients with these conditions. So what was the kind of framework for thinking about this? And again, you're going to see why this comes back to ketogenic diet, but it's important, I think, to understand the context for this. So Laborie then performed extensive investigations of the mechanisms of action of chlorpromazine and the first antipsychotics, thienocyanins. And he reported that they redirected brain metabolism by, when glucose comes into the mitochondria and is processed for energy, this is what kind of contributes to these very high energy states. It was a kind of rapid burning of sugar in the brain. And we see this in brain imaging studies, and we see it in PET imaging studies in mental health conditions, that glucose during seizure, during mania, and potentially during psychotic states is burning at a very rapid rate. We know this from brain imaging studies. So this is a really core feature. If you know someone that has a condition like this or you live with it, is to understand that when they're in these manic states and psychotic states, it's likely that their brain is burning through energy, burning through glucose at a very rapid rate. And what Laborie thought happened with chlorpromazine was that instead of glucose going through the normal energy pathway, you can see on the left here this kind of waterfall of glycolysis leading into the citric acid cycle. This is how sugar is processed in the body. He believed it shunted glucose in a different direction towards the pentose phosphate pathway. And this is more like a repair and rebuild pathway. So if you're thinking about like evolutionary dynamics, the body had to shift between having high energy states for survival scenarios, and it had to shift into rest and repair states to kind of rebuild and conserve resources. And Laborie believed, he actually called it artificial hibernation in a kind of evolutionary paradigm. that he actually believed that what this was doing was turning down the main engine of the body, the citric acid cycle and glycolysis, and then shunting glucose into the pentose phosphate pathway for these kind of repair and rebuild mechanisms. So this was right at the center of the start of the treatment for mental health. And then he said, well, how can we try to do this in a more sophisticated way? And he started trying to develop other ways of achieving the same effect of turning down this fight-flight response, this rapid burning of energy in the brain, and inducing these kind of more repair and rebuild pathways. Again, he was thinking about this in evolutionary dynamics. He was thinking about fight or flight or rest and rebuild. And he was trying to enhance the rest and rebuild pathways and reduce the fight or flight pathways. So he developed a medication called 4-hydroxybutyrate, which he believed could stabilize brain metabolism. And this was him at the kind of culmination of all of his research, everything he learned about metabolism in these mental health conditions. He has many textbooks that they're now out of print. I've had to go and find them from libraries all over the world. This is pharmacology and metabolism. This is regulation of metabolism. This is stress and cellular function, talk about evolutionary dynamics. And they're all out of print now, so I've had to go through it's an absolute nightmare to find these things, but I've got them all now. They're in French. I've been translating them to English to try and understand what he was aiming towards. But through all these texts, the culmination of this, he tried to develop a medication to help, and it was 4-hydroxybutyrate. And the terminology might sound very familiar to those of you who are interested in ketogenic diet, and I'm going to come back later in this talk to explain why this isn't significant. So to summarize, at the very roots of psychiatry, the person who defined bipolar disorder as a condition and founded the whole field of modern psychiatry, Emil Kraepelin, said these are marked disorders of metabolism and they're at the interface of physical and mental health. And he was very committed to this idea. And Henry Laborie, who developed the very first pharmacological treatment for mental health, he developed a framework of understanding this, which was an evolutionary framework about states of hypermetabolism in the brain and how to reduce these. And then he developed this medication to try to address this. And we'll come back to why this medication that he addressed is significant for our metabolic psychiatry research. So the last thing about Laborie was that he also believed it wasn't just about neurons, it was about the interaction between astrocytes and neurons. It was about the metabolic shuttling that astrocytes provide to neurons. So astrocytes are these kind of support network in the brain that provide energy and resources to neurons to function. And he proposed that at the root of metabolic dysfunction in psychiatric conditions and these hypermetabolic states was a dysfunction of this astrocyte and neuron dynamics, the metabolic coupling between astrocytes and neurons. So he was very ahead of his time in proposing shuttling of lactate fuel source from astrocytes to neurons. And the overall framework, again, he was looking at was an evolutionary framework. He said the modern environment is dysregulating the metabolism in our brain, and we need to find ways to treat this. And his way was called artificial hibernation, reducing the metabolic rate in the brain and putting people into these suppressed and kind of hibernating type states to suppress this fight or flight mechanism. And he had this specific mechanism that I described earlier of how he thinks chlorpromazine does this. So this addressed the hypermetabolic states, but we really need to find solutions for patients who are in the depressed metabolic states, who can't function, who can't get out of bed, who can't work. There was many times in my life where I was not able to leave the house for 2 months on end because I was in these very profound states of metabolic depression. It's quite a scary thing to experience, particularly if you're looking after a family or have work commitments. And really, this was my journey, was to try to overcome these depressive states. That was my main struggle with bipolar disorder. So at the very beginning of psychopharmacology, Laborie conceptualized psychiatric conditions as conditions of metabolic dysregulation in the brain. He believed that they represented an evolutionary mismatch with the modern environment, resulting in states of sustained hypermetabolism in the brain. He introduced the first antipsychotic medication, chlorpromazine, to psychiatry and described metabolic mechanisms of action of this medication. He emphasized a focus on the metabolic coupling between astrocytes and neurons, a central feature of the metabolic dysregulation occurring in these conditions. So now I'll present the results of our pilot study of a ketogenic diet for bipolar disorder. And this came about through my own journey. I was doing this diet to lose weight. I was very unwell at the time. I'd had a period where I was, before I was a scientist, I worked as a composer. And this is how I kind of channeled my bipolar hypomanic states into something productive. And I worked as the assistant to a film composer called Harry Gregson Williams. And I became quite unwell during this time, and I was involved in a car crash, and I went back to the UK, and I had 2 months where I couldn't leave the house. I was literally hibernating. I was really, I couldn't move, I couldn't think, I couldn't feel, and my wife became very worried about me. And I realized I have to try and find new ways to address this condition because I'm not well enough to have a family, to have anything normal in my life, to have a career, to have a job, to contribute in any meaningful way in the world. So I started trying everything I could think of, and I decided at least I'm going to try and lose some weight because that's something I might be able to do that would improve my health. And I don't think it'll make any difference to my mood, but let's try this. And when I did this, I did a sort of very strict kind of form of the Atkins diet. And I noticed for periods that I was having remission and wellness, and I couldn't understand why this was the case. So I started to research it, and I learned about ketone levels. And I learned that as my ketone levels went up, there was a reduction in my symptoms. And then I met Jan and Matt Bazuki, who had been through this journey themselves. For many years, I couldn't get funding, or I was turned down from every grant application, fellowship application. But I worked a day job, and I worked in the evenings till 2 or 3 in the morning, trying to understand what this was about. And I put up a video on YouTube at one point to kind of raise awareness about this. And it was found by Chris Palmer and then by Jan Bazuki. And I met the Bazuki family, whose son had been through this exact same journey, and they wanted to fund research in this. So we did this pilot study of a ketogenic diet for bipolar disorder. So this was a small pilot study examining feasibility and acceptability of the intervention. We recruited 27 participants and 20 completed the study. And we had very good completeness of the measurements we took, which were daily mood measures and daily sampling of glucose and ketones. And people achieved light ketosis in 1 to 7 days of commencing the ketogenic diet, and optimal ketosis in 3 to 13 days. And the results of this study are published in 2 publications in the British Journal of Psychiatry Open, which you can find here at the bottom of this slide. So could participants with bipolar adhere to a ketogenic diet? We find yes, patients were actually remarkably adherent to this diet. 91% of the time of all the readings we took in of the patients, they were in ketosis, defined as over 0.5 millimolars of beta-hydroxybutyrate. And this was, you can see the levels of ketosis on the left here, and many were achieving optimal and high levels of ketosis. This is very much thanks to Helen Grossi, who is the NHS ketogenic diet coordinator for the north of Scotland, who carried out this study. And she really did a remarkable job in keeping these patients in consistent states of ketosis. So this was just a slide describing, we've described what a big problem metabolism is: substantial metabolic burden, obesity and overweight, twofold risk of type 2 diabetes, and people dying 10 to 15 years younger than an average person from these kind of physical metabolic conditions. So across the patients, we saw first a weight loss of 4.2 kilograms on average, a maximum of 10 kilograms and a minimum of 0.2. And this was quite a substantial weight loss for people that are on these medications. As I say, they cause metabolic dysfunction. So to see that they lost 4.2 kilograms over 8 weeks was quite encouraging. And they had a mean BMI decrease of 5.31%. They also reduced their blood pressure by 7 units, their systolic blood pressure. And they had an insignificant reduction in their diastolic blood pressure. So these were really encouraging physical health findings from this study, because these are major problems for people with bipolar, and particularly when you're on these medications that suppress metabolic function. It's nice to see there's a treatment you can add on to this. All the patients remained on their medication as usual, and we just added on ketogenic diet, and we saw these improvements in physical health parameters. We also did blood tests and looked at metabolic changes. And we saw, obviously, increases in beta-hydroxybutyrate, which is the main ketone body. On the left here is the average beta-hydroxybutyrate levels before and after adhering to the diet. And on the right, you can see the individual levels of the participants changing. We also saw a decrease in lactate. And lactate is quite interesting because when you have impaired metabolism in the body through mitochondrial function, apologies, I'm getting over a small cold here. You see decreases in lactate. And this is interesting because mitochondrial function has been implicated. I don't know if any of you've read Chris Palmer's Brain Energy or Georgia Eads' work or Martin Picard's work, but mitochondrial function is implicated in these mental health conditions. And if you have impaired mitochondrial function, you get increased levels of lactate. So we saw lactate come down significantly in these patients over the course of the study, which was quite interesting. We also saw an increase in citrate, which is a metabolite in the mitochondria and the citric acid cycle. It's difficult to interpret exactly what this means, but it's a metabolite within the citric acid cycle involved in energy production. So then we did brain imaging. This is me on the left here testing out the brain imaging protocol, and they couldn't find anyone to do it, so I went it myself. But they had a TV in there where you can watch TV while you're in the scan. And we tried to find something really relaxing, so we were testing out different options for what people could watch while they're in the scanner. And I said put something relaxing on, nature documentary, something like that. It's great. And so I was watching a documentary. It was in the Arctic, and within about 5 minutes of this documentary starting, a polar bear is attacking a seal, and it's very graphic. And I was locked in the scanner and couldn't escape from this, so we had to change, and I think we went with the Disney Channel or something eventually. But we use point resolve spectroscopy, the PRESS technique, which is basically a way of looking at certain regions of the brain. And we looked at three core regions in the brain: the posterior cingulate cortex, the anterior cingulate cortex, and the right dorsolateral prefrontal cortex. And these are just regions of the brain that are implicated in bipolar. We wanted to see what changed in those. So what we found was very interesting because we saw a significant reduction in glutamate. And glutamate is interesting because ketogenic diet is an epilepsy intervention developed over 100 years of clinical use in epilepsy and 13 randomized controlled trials. And one of the key features of epilepsy is elevated glutamate, this excitatory activity in the brain. And we also see this in bipolar disorder. It's associated with mania. Glutamate is considered an excitatory neurotransmitter. And this kind of drives, these high energy, like high activation states in the brain. And we saw this come down by 11.6% in one brain region and 13.6% in another brain region. And this is quite a large reduction. If you look at like anti-seizure medications, like lamotrigine, you might find over 3 months like a 6% reduction in the literature. And we were seeing kind of 11 or 13% reductions. So these are substantial reductions in glutamate. And I can't find many anywhere in the literature that are like this. And this was just using a diet for 8 weeks. So I find this quite interesting, and we'll come back to a bit more about why this might be relevant. And then we looked at psychiatric outcomes. So these were all euthymic patients. They weren't people that were experiencing mania or depression at the time of the study, because a pilot study is primarily to examine safety and feasibility. And so we looked at subclinical symptoms, which are the variation of symptoms within the euthymic range. So we took their mood and their ketone level every day, and we compared these, and we tried to look for, like I experienced, I did this myself for a year leading up to this pilot study, and I saw a correlation between my ketone level increasing and improved mood stability. And we wanted to understand in these patients, could we observe something similar? So we did see significant correlations between the ketone level and their daily mood symptoms. And we didn't expect to see this because in pilot studies, there's a lot of new techniques you're using. It's very complicated. And measuring this is quite a complicated thing, but we did get good data from 14 of our participants where they measured this almost every single day and the ketone level almost every single day. And you can see that mood is generally trending upwards, impulsivity trending downwards, energy trending upwards, and anxiety trending downwards, and no effect on speed of thought. So these were just a kind of clue, I think, that there's something here, even in patients who are well and euthymic, there's something that is improving in their functioning. And over a third of our patients, when we asked them to come off the diet per the protocol at the end of the study, said, we don't want to come off this, we want to remain because it's helping us physical health and mental health. And we recorded interviews to try and understand why this might be the case. So I'll share with you one patient who describes their experience with this. This is an example of someone else in the study who experienced this improvement, minus 22 pounds of weight loss. They reduced their insulin resistance, their HOMA-IR, they reduced their BMI and reduced their blood pressure. And again, you can see this kind of correlation between their ketone level increasing and trends upwards in their mood and energy and downwards in their anxiety. So this was a patient from the study who shared their experience. And this is, there's several patients now who've become advocates for this treatment from the study. Oliver Seligman is another one who has spoken publicly on his YouTube channel, Thriving with Bipolar, about his experience. And he's actually writing a book about his experience on the pilot study, which I think is quite a remarkable outcome from a small pilot study. But this was a participant on the study, and I'll let her describe it in her own words.
Everything I've tried, over the years since my diagnosis has not kept me in balance, has not, it's been, so when I started to get into ketosis, it just got better and better. It was to the point where it was night and day. I had pains and aches that went away, but I got my brain back. It's like I got my brain back. So I had issues with memory when I'm feeling ill and unbalanced, anxiety, just those things just went away. I liked who I was. I liked how, I could think again. It gave me, and I said this to somebody, said, I've got hope. Like I was losing hope as I get older. things were just going to get worse and worse for me, and I was going to have more and more symptoms to deal with and more times of illness. And this has given me hope. And I remember at some point just sitting and having a cup of tea and thinking, oh, I wonder if this is what it's like for most people. Wow, okay. I'm just so grateful. I can't, I've never been more grateful for, anything, in the fact that people are looking at this is just, it's a deep sense of gratitude. I was asking Helen about being a dietitian, so maybe it'll be that. But that's how major the impact on me has been, like completely life-changing.
So this was, this was during a time when I worked for a very long time to try and get this pilot study done. There was many times actually when I'd just been turned down from so many grant applications or fellowships. I was working a full-time day job. I was having 2 kids, and it was really like there's many times it felt this is just never going to happen. And to meet patients from the trial who were experiencing benefits, I found it very moving. But then, I'm a scientist and I have to remain objective about these things. But primarily what I care about is patients getting better. Nothing in my research really matters to me unless patients are getting better from it. And so I've loved hearing the testimonial from, this participant continues to work with us on a randomized control trial we're working on. And there's another, you can find on a channel called Keto Bipolar. It's a podcast that I have with Matt Bazuki, one of the other participants from the pilot study called Oliver Seligman. I think it's the latest episode describing his experience on the pilot study. So in any trial, there's going to be adverse events, and we saw ones that you would expect to see in epilepsy. And we documented these quite rigorously. It's very important to try and understand exactly all the things that in the early pilot studies that could happen to patients. So we were extremely meticulous with documenting these, and most of these were mild and modifiable. However, we did have one serious adverse event, which was a very high level of ketosis with euglycemia in a participant taking a SGLT2 inhibitor. So there's interactions with diabetes medications that we'll need to understand a lot more about in psychiatric treatment. And we've started, and we share this at every talk to make sure that people are aware of these. The participant was recovered within a day and was withdrawn from the study. So we really need to be careful of this as a medical intervention, not just a diet that people can go on without any support or help. So in summary, we had good ketogenic diet adherence and levels of ketosis achieved. We had high levels of completeness of capillary sampling and EMA data, and significant improvements in weight, BMI, and systolic blood pressure on average across the participants. There was a significant positive correlation between ketone level and the daily assessments we had of mood, energy, and a negative correlation with anxiety and impulsivity. The brain imaging results showed 11.6% reduction in brain glutamate and a 13.6% reduction in another brain region after the 6 to 8 week ketogenic diet. Adverse events were generally mild and modifiable. One serious adverse event, high levels of ketosis, occurred in a participant taking SGLT2 medication. And qualitative patient reports were substantial responses to the diet as well as challenges of adherence. And over a third, when we asked them to come off we did a washout period to come off the diet, and over a third said we won't participate in the washout period because this is helping us. So these were indications that we should investigate this in a larger trial. And we're now moving on to a large RCT, which will be happening next year. And if anyone is based in the UK or knows people with these conditions based in the UK, please do email me because we'll be having 206 participants in this trial. It'll be the largest RCT in metabolic psychiatry examining ketogenic diet, and we really want to include people that could be helped through this. I'm excited about it on a scientific level, but more so I'm actually just excited about the patient responses and the prospect that people might get better through this trial. So please do get in touch if you know someone that'd be interested. So at the start of this talk, we talked about Labourier's idea of 4-hydroxybutyrate and this paradigm of thinking about these psychiatric conditions as hypermetabolic states in the brain. And he eventually came to this conclusion that these medications that he was developing work through stopping these hypermetabolic states by redirecting the glucose pathways in the brain. And he developed this medication called 4-hydroxybutyrate, sometimes called gamma-hydroxybutyrate, you can see on the bottom here. And he saw this as a way to try and manage brain metabolism to shift it in a different direction. But what's remarkable about this project was that right at the very root of mental health treatment with antipsychotics He called this a ketone body. It's called 4-hydroxybutyrate, and he said in his text, I've developed a ketone body that I think could help to manage these hypermetabolic states in the brain. And actually, 4-hydroxybutyrate is a very close structural analog of the primary ketone body, beta-hydroxybutyrate. And this is what we measured in our pilot study. So we measured the levels of 3-hydroxybutyrate, beta-hydroxybutyrate, and we've seen that this has changes on the brain that are meaningful with glutamate reductions. So right at the roots of trying to treat these conditions in pharmacology was this idea that we're trying to stabilize brain metabolism. And he actually developed, it's not technically a ketone body, but pragmatically he called it a ketone body. And it's a very close structural analog of the primary ketone body. And so we're now revisiting this almost 100 years later, more than 100 years later. Less than 100 years later, to try and understand what could be the role of 3-hydroxybutyrate, beta-hydroxybutyrate. So you recall as well that the second thing that Labouré said right at the beginning of how we started to treat these conditions was about the metabolic transfer between astrocytes and neurons. It's not just about the neurons, it's about the support network for the neurons, these astrocytes. And this is where it's important, I think, to talk about glutamate. So many of our mental health treatments focus on modulating monoamine neurotransmitters, serotonin, dopamine, and so forth. And when you look into what these neurotransmitters are, when we're doing brain imaging or a study, I was saying, why don't we detect serotonin and dopamine? We're detecting glutamate quite easily. What about, serotonin and dopamine? These are very important in mental health. And our imaging specialist was saying to me that actually they're very hard to detect these things. They're tiny fractions in the brain compared to glutamate. And I was saying, well, how much smaller is it? And they're actually, glutamate is existing in orders of magnitude greater concentrations in the brain than all of these other neurotransmitters. In fact, it exists in micromolar, glutamate exists in the brain in millimolar concentrations, whereas the other neurotransmitters are existing in micromolar concentrations. Trying to go back to show you here. So glutamate is present in millimolar concentrations, and all these other neurotransmitters are micromolar concentrations. So I was interested in this because I thought we've seen this reduction of glutamate in the brain that's quite substantial in the study. What is happening with glutamate? It seems like there's something we're not understanding. It's one of the most common biomarkers for both epilepsy and bipolar. And here we are studying this epilepsy treatment that's been used for 100 years that has effects on brain glutamate. And when we apply it to bipolar patients, we're seeing effects on brain glutamate in a ketogenic state. So I started to wonder, why might this be the case? So I'm going to give you a very rough analogy, but it will give you a kind of a feeling for how this is in the brain. I apologize that this is slightly imprecise because we can't really measure these things in a precise way, but I want to give you an idea of just how significant glutamate is in the brain, because we hear so much about serotonin, dopamine, and the others. But glutamate is by far the most abundant neurotransmitter in the brain. So to try and visualize this, let's scale up the concentrations to get a sense for how predominant glutamate is in the brain. So if you were to take a kind of bathtub and fill it up with the neurotransmitters in the brain in the relative proportions, you would be filling it almost right to the brim with glutamate, like 200 liters. The brain is just full of glutamate, is flooded with glutamate. And then you would take GABA, which is the next most abundant, which is like about 20 liters would be in this bathtub. So these are the two most prevalent neurotransmitters in the brain by volume. And then you take acetylcholine, which is quite important, and this would be like a small beaker you'd be adding in on top of this. And in terms of concentrations in the brain, if you took dopamine, it would be like a tiny cap. It would be almost like a toothpaste cap full of dopamine is how the kind of concentration this exists in the brain. And serotonin, similarly, like a very small cap. So you can see in this analogy, it's very rough, and I apologize for that. We can't precisely measure these things in the way that would make this, and maybe we can in the future. But essentially, the brain is really running on glutamate and GABA as the brakes and the accelerator of the brain, and then you get smaller degrees of these other neurotransmitters. And it's estimated that glutamate-mediated neurotransmission is responsible for about 80% of the energy expended in the grey matter of the brain. But what's also remarkable about glutamate is it's not just a neurotransmitter, it's also a metabolic fuel source in the brain. It is an actively burned fuel source in the mitochondria. It's converted to through a specific process into
Iain,
the citric acid.
Iain,
Yeah.
sorry to interrupt you. Can you wrap up within about 5 minutes?
Yes, we can.
Yeah,
Yes.
thanks.
So just to summarize, glutamate is very important. It's one of the most prevalent neurotransmitters, and it gets very little attention compared to others. But we saw this reduce in our pilot study And I just want to draw attention to this paper you could read after this talk, which is where I tried to describe why this might be the case. And this is describing the mechanism where glutamate is burned in the brain during high energy states in seizure, in mania, in states like this. I think that glutamate is being burned in the brain. It's being produced from glucose and burned at a very rapid rate. And I present evidence in Nature Molecular Psychiatry why I think this is the case. And this is something, this would explain potentially why ketone bodies, when they come into the citric acid cycle, displace this kind of high, rapid burning of glutamate in the brain. So I agree with Lavery that this is about the astrocyte and neuron coupling. Astrocytes feeding, burning glucose at a very rapid rate and feeding glutamate into neurons. And I think this is what might underpin some of these hypermetabolic states in the brain. But certainly I think it's a helpful way to think about these conditions as very high energy states in the brain. So is there a bigger evolutionary picture to this in the last 5 minutes? So going back to Emil Kraepelin, who was the first psychiatrist to define bipolar disorder, he said repeatedly in these cases, I saw moodiness set in the autumn and pass over in the spring when the sap shoots in the trees. And this was him describing the seasonal variation of symptoms in bipolar. And if you look at the hospitalizations of bipolar disorder, you can see in the red here, the manic episodes really peak in the spring and the depressive episodes really peak in the winter. And there's also a second peak of mania in the autumn, the smaller red peak. And these are associated with the rapid change of photoperiod. So the length of daylight is changing very rapidly at these times. And these are the times that people get hospitalized for mania. And also during the winter in depression, when the photoperiod is reduced, there's less daylight, people are getting hospitalized for depression. We did an art exhibition about this with patients in Iceland recently, with patients that we work with, showing art they'd made that describes these kind of different states in the different seasons. So why might this occur? Well, your metabolism is very much tied to seasonal variation. It's modulated by light exposure. And you can see here the metabolic pathways, that the gene expression in humans is on this kind of cycle. This green line is a cycle through the seasons of different expression of metabolic pathways. It's quite profound. And it revolves around times of changing light at the equinoxes and the solstices. But you can also see this in the animal kingdom. There's analogies from nature that kind of give us an insight into these metabolic changes in the seasons. This is an animal who's encaged, and during the spring equinox, it starts behaving like this. It's the middle of the night, and it's flapping its wings violently, trying to break out of the cage. It will actually bash its head off the cage and try to escape. And it has this, they detect this very profound hypermetabolic state with high activity levels. And it occurs twice a year at the spring equinox and at the autumn equinox. And you'll recall from the previous slide, these are the two times that patients experience mania with bipolar disorder and are hospitalized. So this, what we couldn't understand until we saw these animals in nature, was that this animal is a migrating animal. It's designed as a deep evolutionary program to travel tens of thousands of kilometers across the ocean and start a new home at these times. It upregulates its metabolism into hypermetabolic states. It has very high energy, insomnia, it's up all night, it doesn't sleep for days on end. But isn't this a little bit like psychiatric patients in an asylum? Look at this patient who's under artificial light conditions, encaged in this enclosure, and he's becoming confused, and he's saying to a psychiatrist, I need to be outside. Look at how he looks at the lights, and he's confused, and he's like, why are these bright lights shining on me? He wants to be in a natural environment, and he's describing this, that he wants to go outside to a psychiatrist. And if you look at the changes that occur in these patients, these are changes in glutamate. So in the spring, if you look at the changes that happen in bipolar disorder, these are changes in the glutamate energy system, and particularly how glutamate is used for energy. So in the last 2 minutes, I'll quickly describe as well that not only are the hypermetabolic states an interesting evolutionary analogy for bipolar and psychosis, but the metabolic depression that happens in winter is quite a profound analogy for bipolar disorder, as you saw hospitalizations for depression happen in the winter. And during this time, animals are really suppressing their metabolism to the lowest function possible to conserve energy, but they also upregulate ketosis. So in the diagram you can see on the left here, they're suppressing their glucose metabolism, suppressing their overall function, but upregulating ketones as an alternative energy to carry them through these times of metabolic depression. And I think this might be a sort of clue as to why ketosis might be helpful in bipolar, because if you have this very profound state of depressed glucose metabolism, depressed metabolic function during the depressed state, maybe ketones are the evolutionary required adaptation for these types of states. Maybe you need ketones to carry you through these forms of metabolic depression. And this is what I experienced, was relief from depression whilst in ketosis. So just to summarize, Emil Kraepelin in 1921 remarkably actually proposed this. He said that Stransky, his colleague, also searches for an explanation of manic depressive insanity from the point of view of metabolic disorders. He emphasizes the ancestral relations between emotional life and periodicity. So right at the very first definition of bipolar, right at the kind of founder of modern psychiatry, he was saying maybe there's an evolutionary ancestral dynamic that explains why we have these states of dysregulated metabolism in the brain. Labre tried to fix this with pharmacology. He ended up developing a ketone body. But now we're coming back in metabolic psychiatry to study an epilepsy therapy called ketogenic diet, which induces ketosis through a different mechanism. So bipolar disorder may represent a kind of breakdown of evolutionary conserved chronometabolic survival mechanisms. And this speaks to Labre's idea about the idea of hypermetabolism and a mismatch with our modern environment. So I like this quote from Brett Weinstein, an evolutionary biologist. He says, "We are beautifully designed for a world we no longer live in. And perhaps by reintroducing these ancestral signals to our biology, we can regulate our metabolism and prevent these hypermetabolic and hyperdepressed states that were adaptive in the natural environment for animals and humans to overcome environmental challenges. But in the modern environment, these same capacities that made us so adapt to survive and to thrive in the world can become heavily dysregulated by our modern conditions of artificial light and artificial food. And maybe this is contributing to some of the problems we see in psychiatry. So thank you very much to my colleagues in the Hub for Metabolic Psychiatry at Edinburgh. And if you'd like to contact me, these are my details. Thank you to Jan, David and Matt and Bazooki Group who funded this research, and Daniel Smith in the Hub for Metabolic Psychiatry.